All right, so valve disease. So valves are assessed by an echo. That's usually what has been replaced at. So in 1983, the echo was invented, and then now that's kind of, and also we found another valve disorder at that time. We found mitral valve prolapse. But then after a while, that's usually, the skill of auscultating and knowing which kind of murmur it is, and has kind of faded into just using an echo, right, to confirm, right? So if you tell a provider, hey, I hear a murmur, I think it's a systolic murmur, I think it might be a mitral valve, stenosis, or they're going to tell you, no, it's an echo, right? So that's kind of unfortunately where it's gone to, but this will help you understand hemodynamics. We talk about CVP and the A line and such, about when the valves close and all these other pieces. And usually the things that you have to know is, when is it systolic or diastolic? That's going to tell me if it's a mitral stenosis or a mitral regurg, because you auscultate on the chest and you hear it best over the mitral area versus the aortic area. That means, and it's a systolic murmur, I'm going to hear mitral regurg more during systole than I would a aortic stenosis, for instance. And yeah, there's some tests we can do. There's some maneuvers we can do to assess that, but usually the maneuver they're going to say is get an echo, right? There's other things we can do. We can have the patient squat. It's like, I'm not seeing an ICU patient do a squat, but you can like raise the legs to increase blood flow to see if you hear the murmur better. There's other different tricks you can do, and we'll kind of touch on them, but we're not going to go into too much detail, right? And of course, auscultation. It's like, where do you auscultate it best is usually that murmur. If I hear it best over the aortic area, it's probably an aortic valve situation. It's either aortic regurg or aortic stenosis. The next step, or the first step, would have been, is it systolic or diastolic? Because there's only one systolic aortic murmur. There's only one diastolic aortic murmur. There's nothing else, right? So that's the idea behind valves, all right? So knowing flow of blood through the heart is, of course, you have to know that, because things are going to start backing up in other chambers when you don't have forward flow because of a valve, or you have regurgitation into that chamber. All right, so valve disease is due to a defect or damage to a valve, right? It could be multiple valves at once, but usually it's one valve, and maybe the next valve might get hurt or get upset. But there's something going on between a chamber and a vessel, or a chamber and a chamber. So we have, between chambers and chambers, we have the AV valves, right? AV valves are the valves that are between the atria and the ventricles. So this would be an AV valve. That's an AV valve. That's an AV valve, right? Between the right atria and the right ventricle, or the left atrium and the left ventricle. Those are atrioventricular valves, or AV valves, right? And they are what open when you're during diastole, right? They have to be open, otherwise you can't diastole, right? Otherwise, blood can't go from the atria to the ventricles. So you need to have those valves open. When a valve opens, it should not make any noise. It's absolutely silent when a valve opens, right? It's only when valves close that you hear something. So the valves close, or let's say the AV valves close, what's going to happen? Systole or diastole? Systole. So AV valves are closing, right? S1, S2, they close. The first sound you hear is the onset of systole, right? If they were open at the onset of systole, then you would be pumping blood back into the atria, right? So the atria will dump into the ventricles, right? It's about like 80 to 90% of it is passive. The other 10 to 20% is the atrial kick, right? And that's all blood is going to go into the ventricles, and the valves close behind it. So they don't leak back up into the other chamber they just came from. And now they're closed, and then now we're going to squeeze all the blood out into the periphery, right? Whether it be the pulmonary arteries or the systemic arteries, right? So that's S1 is the closure of the AV valves. And then the other valves we have are semilunar valves, right? Semilunar valves are valves that are between a ventricle and an artery, whether it be the right ventricle and the pulmonary artery, or on the other side here, the left ventricle and the aorta, I should say, right? So that's our normal flow of our blood through the heart, and therefore, semilunar valves, they should be open or closed during systole. Should be open, right? You want this valve open when my ventricle is contracting, right? I want that to be open so that blood flows outwards, right? because the AV valve is just closed. One set's open and one set's closed at all times, right? They never both close. Well, they are technically closed for like a millisecond or so, but they are, for forward flow to happen of blood, you need to have one set open and one set closed. If one set opens partially, it's going to start making turbulent noise, right? Or non-laminar flow of blood, right? It's going to start causing a lot of sound, or a murmur. A murmur is just turbulent blood flow. That's all you're auscultating, right? You're not auscultating heart sounds. Yes, it is a heart sound, but a heart sound is S1, S2, S3, S4. Again, in the 1800s, they weren't creative, right? They weren't calling it skibbity 1, skibbity 2. They're calling sound 1, sound 2, sound 3, sound 4, right? Normal sound 1, sound 2 is just S1, S2. When we talk about S3, S4, those are abnormal, right? There are some normal variants like pregnancy in kids, but S3, S4 are abnormal. S1, S2 is the normal sounds, right? And why does this happen? It's because we have structural changes like we mentioned with CHF, right? It just dilates out. Look at that huge CHF. Look at this valve from before or after from before, right? It's much more dilated out, and now much more at risk for that mitral valve to leak, right? When something is leaky in valve terms, it's called regurgitation or regurgitant, right? It's regurgitating into the previous chamber, right? If it can't get out of the chamber, like this one right here, see how that's all it's sclerosed and stenosed, and it has all kinds of stuff on it, scar tissue on it, calcification on it. That makes it very, very difficult to get the blood out, right? So some of it might get through, but that's called a stenotic valve. So you have stenotic valves and regurgitant valves. Those are the only two flavors, right? Stenotic or regurgitant. But what about prolapse? Again, that was invented in 1983. It is not symptomatic. It is not something that you can, I mean, yes, there are rare signs, but it's a precursor to regurgitation. So I say, well, but now we can get it ahead while we're ahead. But it's not something that is, that's not, it's very, very innocuous compared to something like aortic stenosis, which is our worst valve disorder, right? So why would that happen? Again, age could do it. You get calcification with age. You can calcify off your aortic valve, I should say. Okay. Infectious disease, another important reason why we might get valve disease is they have infective endocarditis. How do you get infective endocarditis? IV drug use, right? Usually affects the right ventricle valves, or the right-sided valves, the tricuspid valve, for instance. And then CLABSIs, right? So CLABSIs are central line associated bloodstream infections. That's why we do those whole packets and bundles to make sure we avoid infective endocarditis. Okay, rheumatic fever is not usually seen in America. All right, so that's the idea behind valves and what they're all about. So S1 is the onset of systole, S2 is the onset of diastole. And the diastole onsets when the semilunar valves close, right? You want these valves closed right there in the middle, right? That's between the left ventricle and the aorta and the right ventricle and the pulmonary artery, because we want the other valves to open and fill up our ventricles for the next cycle. All right, so the cardiac cycle. All right, so valves open due to changes in pressures. They're designed to open and close based on changes in pressures within the heart. So when the pressure gets higher and higher and higher, some valves are going to close, other ones are open, and vice versa, right? So in red here is our A-line tracing. So we'll talk about A-line tracings in our next lecture, but these guys it makes sense why we get the A-line tracing we do. And it makes sense why we get the CVP tracing we do. So we can hook up a vein to our monitor, usually a central vein, right? And you can hook up an artery to the monitor and we can see the impulses. We can make assumptions about what's going on inside the heart and what's going inside the body based on these tracings, right? So the first thing that happens in the cardiac cycle, you got to start somewhere. You got to start either in systole or diastole. So we're going to start in diastole, right? So in diastole, we're going to start, and we are filling our ventricle, right? So our systolic volume, or our volume, is going to fill until it ejects, right? Why does that happen? Well, we passively fill our ventricles. We're passively filling it up. The pressure is going to rise, and we get this huge bump or kick, right? That's the atrial kick. The atrial is going to kick at the end of diastole, and it's going to supply about 10 to 20% of our cardiac output, right, of our stroke volume as well. All right, and then once it kicks into the chamber, into the left ventricle or right ventricle, it kicks at the same time, hopefully. It's going to then what? These valves should close, right, between the atrium and the ventricles. We kicked all the blood in there, and we slammed the door behind ourselves, right? That way all the blood is locked inside that left ventricle or right ventricle. And the next step is that we're going to do what? We need to make it so that we have a ejection of blood. How do you make the heart eject blood? You say, go. You do it. You got this. How do you make the heart contract? How do you make the atria contract? You say, kick it. You got this. Field goal. No, how'd you do it? There you go, depolarization. You use the EKG, right? So the EKG, you've got P-wave depolarization. What follows depolarization is mechanical activity, right? What follows QRS is mechanical activity. We have contraction of the heart at that point. And now we are in business. Now we change the pressures, and we close the AV valves, we open the semilunar valves, and now all the blood is flowing out into the aorta or the pulmonary arteries. They flow out simultaneously, right? All that blood flow flows out, and what tells it to stop? It's like, okay, that's enough, I'm done. Turn off the hose. How does it stop? How do you tell your ventricles to stop depolarizing? Calcium's involved. Calcium is what sustains the contraction in your cardiac action potential, but what makes your ventricles say, okay, it's enough? What is it? Sodium? That's just some of the sodium. No, it's repolarization, right? Our T wave is the repolarization of the ventricles, right? You have depolarization, repolarization, depolarization, repolarization. Our ventricles are automatic or automatic or have automaticity, right? Gas node, AV node fire off, creates the P wave. It gets conducted down the ventricles and the bundle of piston in the ventricles, and we get contraction. And then as soon as they contract, they relax because you have repolarized, right? So you repolarize. What follows electroactivity is mechanical activity, right? So we repolarize the ventricles. Now they are relaxed. They are relaxing, right? And the pressure then drops, right? And now the pressure drops. That triggers the valves to start closing and opening again. So now the AV valves are going to open after semilunar valves close, right? So that's how we get this waveform. So those are all the steps that are involved for a normal cardiac cycle. And of course, if we put our catheter on the outside in the radial artery, we can see that happen. We can see a quick upstroke in systole, right? Really quick upstroke in systole, and we can see it kind of fall back down. And then if we're inside the right atrium, we can see that too. We can see the pressures. We can see a little upstroke as the atria kick, right? Because it kicks and you can see that little impulse. And then the C is the closure of the tricuspid valve because you're in the right atrium. You can see a little bump as well. And in the left atrium, you're going to have a gradual rise in pressure during systole. While your ventricles are contracting, your atria are not just sitting there, right? They're filling up with blood. So that's what's happening. You're filling up with blood, and then we have the valve closure, and now we can empty out our atria. So you can see those two waveforms, and it tells you what's going on with the heart, right? So that's the idea between S1, S2. Those are our normal sounds. S3, S4. S3 is where the valve opens. This AV valve opens right here during systole, right? During diastole, our AV valve opens, and then all of a sudden, all that blood's going to slosh into the heart, right? Now, if that valve is open, it's going to slosh like a Wilhelm scream. Whoa! Right? It's going to slosh, and it's like a spittoon, and you're going to hear it, right? You're going to hear that S3. S3 comes right after S2, right? S2 is the opening of the AV valves, closure of the semilunar valves, right? AV valves open, and then all of a sudden we hear another heart sound. And it's because of ventricular dilation. That's why we hear an S3, right? And you hear that in really bad CHF or HFrEF, right? So you think of 3 syllables. And then just on the flip side, what if someone has hypertrophy, HFpEF, right? So the AV valves open, you're like, I got this, let's go, and they run in and they hit their head on the ventricle, right? So that's called, and you're going to hear that right mostly during the atrial kick, right? All the blood's in there, like we can't go anymore, and the atrial kick, like, get in there, and you're going to hear that atrial kick right before the onset of systole, right? So it's bump, bump, bump. All right, so bump, 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 bump is S1, S2, S3, and then bump, 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 bump is S4, S1, S2. All right, so what are your symptoms of valve disease? When you have valve disease, what kind of symptoms do you get? All right, you're going to get a murmur, right? A murmur is a sound, but it's not your heart sounds. The previous slide was your 4 heart sounds, right? These are now we're moving on to murmurs. Murmurs happen when you have abnormal blood flow through the heart. And if you put more blood in the heart, you're going to hear it better. Just like if you have a hose trickling versus a hose that's a full blast, you're going to hear it a lot better when it's a full blast, right? So more blood always means more murmur, except for this MVP. So that's the exception. We'll explain why, but basically when you have more blood, more preload, you're going to get more murmur. How do you make someone's blood, put more blood in someone's heart? Do it. Do it now. No. No, you can raise their legs, you can put more blood in their heart. You can tell them, get out the bed, I got a barbell for you to squat with. All right, so with the ventilator or without the ventilator. So that's something you can do as well, usually in an office setting, right? So squatting, leaning forward, these things can make them put more blood in the heart. Instead of being upright, right, and at 30 degrees, you can lay them flat. That can do it, and you can appreciate the murmur more. And then more afterload is more work on the heart. So if like a aortic stenosis, let's say, right? So, sorry, aortic stenosis is a bad example. So like aortic regurg, for instance. So they are, you push all the blood out of the ventricle and it regurges all the way back into the left ventricle. So if I make that much higher pressure in that whole system, that's going to make the noise even louder. So that's the idea behind why more afterload or more work makes more murmur as well. Okay, so what else? So when you have that more work happening in the atrial ventricles, they're eventually going to dilate or hypertrophy, and if they start dilating, they can start pushing on other structures. So our left atrium here can start pushing onto the esophagus, and they get dysphagia. The atrium can start getting bigger and bigger and bigger and start causing AFib. Right, so these are other things that can happen, and then they are risks now with AFib and also with a dilated chamber. They have a little what's called a little pouch that's outside the atrium, which can start forming clots in it. Right, they do a Watchman's procedure to block those clots from leaving. All right, so in general, they're going to have low cardiac output. So we have our short chest pain, shortness of breath, hypotension, confusion. Another way to look at it is SAD. They're going to get syncopal. They're going to angina, which is chest pain, and dyspnea, which is shortness of breath, right? So chest pain, shortness of breath, and yeah, they can get hypotension as well, especially with the most severe murmur, which is which one? It's your aortic stenosis, right? So how do you know someone has a murmur? You can have really good stethoscope skills and listen to the right, the correct side of the heart. I should say right side, because only on the right side you're going to hear the aortic stuff, right? But you could get an echo. That's what they're going to tell you, right? I hear a murmur. I hear a systolic murmur, right? Yes, I hear best at the aortic area, but the echo is going to tell you what's going on. If you see anything sus on the echo, then it's time to get a 8K snapshot of your heart. Right, because the echo is just like 480p. It's very, very low resolution, right? Like when I was in college, I spent all my FAFSA money on a new TV, right? It's a good $900, and I got a brand new TV. It was 480p, 720i, right? So it's like, yes, I'm in business now. It's the best resolution I've ever seen in my life, right? But then if you really want a really high resolution, that's where you get an 8K image with a TEE. It goes right behind the esophagus, and the atria just touches the esophagus, and you're able to get a great picture of the valves in that view. Okay, and then what else? So TTE versus TEE. TEE obviously involves consent. It's a planned procedure that they undergo. Okay, MRI can be used. Cath lab can be used to evaluate if they're a good candidate for like valve surgery and such. So other things that might be done to fix someone's valves. Obviously, we're going to fix their heart failure. If they're in heart failure and that caused the valve issue, let's fix the heart failure. Or the valve is causing heart failure, let's fix the heart failure also, right? So we reduce preload, we reduce heart rate, blood pressure, the myocardial remodeling. We're stopping all these things from happening, okay? Aortic stenosis is the exception because it's really, truly is preload dependent, right? You don't say, hey, I'm going to reduce the amount of blood flow coming out of your heart, right? Because that's the key piece right there, right? The aortic valve. I'm going to reduce the preload. Now I have less blood coming out. That's not great. And those guys it's a little more tricky to manage them. All right, but in the cath lab, they can do different things. They can do a balloon valvuloplasty where they go in there and they just open up all that scar tissue and calcified tissue. That doesn't work with someone with an aortic valve issue because the aortic valve is very, very calcified, and that's not going to help open up that valve. So they just need a replacement. And we can do that with a aortic valve replacement, or a TAVR. They just go in there and they just scoop out the aortic valve and they replace it with this brand new mechanical valve, right? Sometimes they have really floppy valves. They have valves that are all over the place, and they're hanging out, and they're slapping, into the left atrium, or they're going slapping into the aorta like a regurgitant valve, and they go in there and do what's called a little labiaplasty. They go in there like a snip, and they can sew it back together, and then make it so that it is nice and rejuvenated, right? So you rejuvenate for regurgitation. And then what else? So surgical valve replacement. We can do that again with a TAVR, or we can do it mechanically, or replace it with a mechanical valve with an open heart surgery, or we can replace it with a bioprosthetic valve that we got from a willing pig. Okay, and then mechanical valves, they have to be on anticoagulants for life, whereas bioprosthetic valves, it's usually just for like 6 months. We check to make sure there's no reactions, and then they're good to go. Okay, mechanical valves usually last about 10 years or so. And we mentioned about endocarditis. Endocarditis happens, that could be a reason for valve replacement, but it could also be a reason why we want to avoid any kind of worsening valve dysfunction. It could be a bacterial source that we're trying to mitigate. And someone with a valve replacement has a very, very high risk for infective endocarditis. These are the patients that should be getting on antibiotics before dentist appointments. They should be, if they have a eclampsia, we want to avoid eclampsia by make sure they have good sterile technique with insertion, but but also with with cleaning of the site, right? So endocarditis is very, very deadly, especially with someone that has a valve replacement already. All right, so mitral stenosis. All right, so we're going to start with the easiest, most straightforward valve. All right, so our mitral valve is located where? Between our atrium and ventricles. That makes it an AV valve, an atrioventricular valve, right? And what's happening in mitral stenosis is that the blood cannot get through because it is very, very stenotic, or sclerosed, or occluded, or obstructed. It can't get through, right? So maybe when it does get through, it will then like open the doors and slam them open really quick, right? So sometimes there can be a little opening snap that you can appreciate, but mitral stenosis is where you can't get blood from the left atrium to the left ventricle, right? Therefore, the left atrium can start ballooning out and getting bigger and bigger and bigger, putting at risk for what arrhythmia? AFib, right? So the pressures in the atria go from 10 to like 25. It started increasing the pressures, and that can, now you're in AFib, now we're at higher risk, right? Of developing clots and such. And this can all start backing up into the lungs and start causing, some pulmonary edema and such, some dyspnea exertion, right? Some syncope because they're not getting a lot of blood flow going forward. I mean, is it as bad as aortic stenosis? No, but it's still something that they can be symptomatic from. Okay, so everything, if it can't go forward, it's going to start backing up. It might hypertrophy or it might dilate. It's just a flip of the coin which one it's going to do. All right, what else? So is this systole or diastole that you might have this trouble getting the blood from the atria to the ventricles, from point A to point B? That's definitely diastole, right? Your ventricles fill during diastole, right? And yes, there's such thing as an atrial diastole and an atrial systole and a ventricular diastole and ventricular systole. But when we say systole and diastole, we're talking about the ventricles. All right. And why do you get it late? Right? It's because it's this really when the atrial kick kicks in. So when you kick it through that door, you're gonna get more blood flow through the door, and therefore you get a louder murmur towards the end of the cardiac cycle. All right, what else? So again, more blood, more murmur, more worker, more murmur as well. So if you increase afterload, yeah, it can help. It can increase it, but not as much as if you were to increase preload. That would definitely have an increase in their mitral stenosis murmur. Okay, and where would you hear it best? So apex, otherwise known as the mitral area, right? So murmurs are heard best if they have the murmur. It's usually heard best over that area because that's the flow. That's where the flow of blood is occurring, right? The reason why these areas are called the areas they are is because the aorta, is sloshing through that area. So the aorta is sloshing through this area. That's why the aortic area is there on the right sternal border, right? And then the mitral area is, of course, midclavicular, fifth intercostal space, right? So that's where we would hear mitral murmur better than we would hear it in like the aortic area for systole. So it'd be quieter in the aortic area, louder in the mitral area, and we'd say the systole or diastole, it would be what? Yeah, it'd be a diastolic murmur that I hear best over the mitral area, right? And it has a unique characteristic of an opening stab. So MVP, mitral valve prolapse. So again, this was discovered with the invention of the echo, but you do get, it's really is asymptomatic. It's rare for it to have symptoms, but it can progress to the next murmur of mitral regurg, right? But why do you, and it's different from every other murmur because it's, you put more blood into it, you expect more murmur, right? It's like I should be put more blood into this system where there's a murmur, I should hear it better. But it's different because it's like a parachute opening is why you're hearing this and why you're hearing this abnormal flow as the parachute opens, right? It opens and creates a little click, right? A little click going on, and then blood can regurgitate a little bit. If it fully regurgitation, that's mitral regurg, but a little bit might flow through there, and you can start hearing that murmur, during systole or diastole. When is this happening? During systole, right? Because we are usually pumping blood into the aorta, right, during systole, and then this is causing issues during systole. That's when we're hearing this go off. So we are hearing this parachuting occur. So you imagine it is like these little toys you got from the 80s and 90s, right? Who was born after the 90s? Probably several of you. But anyways, we have these little toys where they would pop open, right? You put them down and they pop open, and then you'd have those things would pop better when there's nothing for it, it can just expand, right? But if you put a lot of pressure on it, it's going more preload, let's say, it was not going to expand as much, right? And same thing with, what causes mitral valve prolapse is the slapping of the valves against each other, right? So if I put more preload in that ventricle, it's not going to make as much sound, right? So that's the idea behind mitral valve prolapse. As I put more preload in there, these valve leaflets are going to match up. If there's less preload, it's going to have less match up, and it's going to slap a lot more. This is going to slap. All right, anyways, we're going to have different maneuvers you can do. Again, they're just going to tell you get an echo. But if you put more preload in there, it actually makes it quieter. It's actually the exception to the rule. Also, if you stand someone up, that empties the ventricles, and you're going to hear it better or worse. You're going to hear it worse. You're going to hear it better. Right? Sorry, I didn't phrase the question correctly. Your mitral valve prolapse will be more pronounced if you stand up. That's going to make the ventricles smaller, right? It's going to empty a lot better. Versus if I raise the feet up, lower the head, that's going to put more blood into the ventricles, like I mentioned, and it's going to make the murmur quieter. All right, so mitral regurg. All right, so again, we are not able to, this is a consequence of mitral valve prolapse, and now it's completely prolapsed, right? Those chordae tendineae that we're holding on for dear life before have either ruptured with like a papillary muscle rupture with an MI, right? Or they are just giving out because your CHF is just so bad, it's just super, super dilated, right? So all that blood's going to start regurgitating in the left atrium. When would it regurgitate? When the valve's not working is a great answer. Yes. So when is that? During systole or diastole?
Mitral regurgitation would be during systole.
During systole. I heard so during systole. So yeah, during systole is when you're pumping blood into the aorta, right? You're pumping blood into the aorta, and then also you're pumping blood into the left atrium, right? And you're going to hear that sound through that regurgitant valve. That valve is floppy and it's not working good. So you're going to hear this murmur best during systole, right? So you hear a systolic murmur that you hear best over the mitral area. And why the mitral area? Because that's where the blood flow is flowing, right? That's where you're hearing this best. It's be more distant if you're listening over the aortic area or the tricuspid area, for instance, right? So you're hearing all this floppy sounds occurring, right? So it's a systolic murmur. Why is it holosystolic? Because it doesn't like have an opening snap or opening click. It's like it's always open, right? You're always hearing this during systole. During diastole, it's just flowing right past. There's not a sound being made, right? It's like it's already open, but it should be closed during systole. It's not, therefore it is regurgitant. All right, so that's the idea. It's a holosystolic murmur during when the mitral valve is regurgitant. Again, more blood through that regurgitant valve is going to make a lot more sound, right? And more afterload, you put more squeeze. I'm going to put more squeeze out into the aorta, and also more squeeze into the left atrium. That's going to be a much louder sound when I do more afterload. How can I make someone's afterload go up? You just have them squeeze their hands. That can do it. You can have them also do a squat. That'll also increase the afterload. Squatting will increase afterload and increase preload. All right, aortic stenosis. So this is the other curveball besides mitral valve prolapse. So aortic stenosis is where the aorta is, the aortic valve is stenotic, meaning that it's sclerosed, calcified, blocked off, it's not able to get through that aortic valve, right? It's like a very, very, very stuck fart, right? So it's unable to get through, and then finally, it's going to come out, right? And it's going to be a crescendo pattern. It's going to be nice and loud, right? Eventually, it'll start off soft, and it can get very, very loud, and then it's going to go away as the gas or blood gets less and less, right? So it has this crescendo, decrescendo pattern, or this louder or soft than loud, and then loud than soft pattern, right? So it is a squeezing through this stenotic valve of the aorta. So when will you hear it best? During systole or diastole? During systole. That's when your ventricles are contracting and pushing blood into the aorta. So you're going to hear it a lot better during systole, or you're going to hear it during systole, I should say, right? You're not going to hear it during diastole because the aortic valve should be closed during diastole, and there's no blood flowing through it at that time, right? So we have a thick, sclerosed, stenosed valve, and therefore why is this the most dangerous one? Because what if it doesn't open at all? That's no blood flow, right? And also your coronaries, which get perfused during diastole, are not going to get the blood flow they need, and then you can quickly present with sudden cardiac death. It's like, well, it's too late at that point, right? But they're definitely going to have a lot of chest pain, right? Because you're not getting blood flow, and then you're going to get a dramatic drop in your cardiac output, which presents with the chest pain, but also they can lead to syncope, and it can even lead to sudden cardiac death, right? So aortic stenosis is one of the more dangerous murmurs. Okay, and then increased stenosis, obviously going to put a lot of stress on that heart there. It might get beefy, it might get weak. We can't tell which one it's going to do, but it's definitely going to cause heart failure, whether it causes HFrEF or HFpEF. It depends on their age and other factors, or they will also have hypertension. There's all kinds of things that are going to play into the story. But it is a systolic murmur because that's when the valve should be open, and it's not opening. Therefore, you're going to get this crescendo decrescendo pattern after S1 or after S2. So it's not quite holosystolic. It is there. It is a systolic murmur, right? At the beginning it might be quiet, and at the end it'll be quiet, but it's not diastolic basically. So it's going to be, so S1 is right here, right? S1 I should say, and S2 is right here. So it's between S1 and S2, right? It's not between S2 and S1. Okay, so it's bump, sh, bump, bump, sh, bump, bump, sh, bump, bump, sh, bump, right? Instead of a normal bump, 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 a diastolic murmur would be a bump, bump, sh, bump, bump, sh, bump, bump, sh, right? So you can tell if it's diastolic or systolic by listening to the heart, right? And figuring out where S1, S2 is, and if it's between S1, S2 or after it. Okay, so again, it's best heard over the aortic area because that's where the aortic valve is, right? That's where this flow of blood is through the aortic area. Therefore, we're going to hear it best there. And it's unique in that, you think if I increase afterload, that might cause it to squeeze out faster. But if you look at the pressures in the system, this is like going with like 200 pressure just to squeeze out all this extra blood out of the ventricle. You're going to get, if you go from 200 to 75 blood pressure, right, diastolic blood pressure, your afterload, if you go from 200 to 75, that's a great, that's a huge noise, right? That's 125 points of noise, right? But if I change that 75 to 100, right, diastolic, that's less noise. So that's why it gets better by increasing afterload, or the noise gets better. Do I want to increase afterload? Not so much, but I can assess it in that fashion. All right, it's like a teapot going off, and if there's less pressure, or there's more pressure on the other side, you're not getting as much noise. All right, so aortic regurg. This one's very straightforward, right? It's an incompetent valve, so it's a valve that is not working. All right, so the valve that's not working is our aortic valve. We pumped blood out during systole, and then we are now expecting that blood to stay on the other side of the aortic valve, but it doesn't because my valve is incompetent, and therefore all the blood falls back into the ventricle, right? So this is a systolic or diastolic murmur. A diastolic murmur, right? So we have a murmur during diastole after S1 or S2? After S2. So it's bump, bump, sh, bump, bump, sh, bump, bump, sh, right? So it has a little crescendo pattern because it's going to be loudest when it falls right back in at the beginning, right? And then why does it happen? Yeah, again, a dilated ventricle. It's getting bigger and bigger and bigger. The aortic valve starts separating and separating and separating, and then you're going to get this effect, or you get this aortic regurg as a consequence. And of course, that's going to put more stress on this left ventricle. It might hypertrophy, it might dilate, depends on what's going on. If they're older, definitely probably going to be dilation. And that's going to then lead to mitral regurg, all kinds of other problems down the road. Right? So again, are we going to hear best over the aortic area or the pulmonic area or the tricuspid area or the mitral area? Of the aortic area, right? That's where the aorta is. My heart sits right here and it goes down, up across the sternum, right? What else? So there's other symptoms you can look at. You can look on the pulse ox, on the A line. You can see if someone has aortic regurg based on that, right? So you can look as long as their blood pressure is stable. Sometimes your blood pressure is you're really vasodilated, and that's the reason why your impulse looks like this. But you can see how this slope here is better than, or is worse than this slope here, right? So someone that has aortic regurg, they're going to have this characteristic where all the blood leaves perfectly fine, right? They don't have a problem with the stenosis. All the blood leaves just fine, and it bounces right back in and like makes a little bouncy noise, right? So you can see this what's called a bifid waveform, and you see a more narrow complex as well, compared to like an aortic stenosis, where it's super hard to get the blood out of the ventricle, just like with an entitled CO2 and bronchospasm. You got a really difficult time getting that air out of the bronchus, right? So that's the slope can actually be brought down a little bit, right? So you can tell based on the pulse ox, A line to be a little more accurate, but pulse ox is also a way to tell. And you can also tell if someone has a high SVR or low SVR just based on the pulse ox. So, oh shoot, they're vasodilated, let's have some pressors, right? You can tell based on that, right? Because when you have really high afterload, everything's squeezing down, right? Someone's super vasoconstricted, it's going to be harder or more difficult to get that blood into that periphery. It's going to be harder. That's why it's going to be wider. It's going to take a lot of time to squeeze all that blood into the periphery, into the arterioles, versus someone super vasodilated. It's going to be super easy, right? Blood's going to come out, it's going to leave. It's going to be super thin, right? So you can tell just based on a pulse ox waveform if someone is vasodilated or not. All right, so yeah, so then also you can tell if someone has aortic regurg and stenosis based on the upstroke. All right, so yeah, so it's a diastolic murmur for aortic regurg. And then they can have this unique, what's called a water hammer pulse, where you see this, you can see this multiple contractions in the neck. Also the fingernails, they lose color as they are compressed, right? You can see the blood be delivered and it just falls right back into the left ventricle, right? So you can appreciate that. So you can see this pulsatile nail bed. Everybody's looking at their nails right now. It's like, yes, no aortic regurg today. All right, so murmur summary. All right, so what is going on with murmurs? This just summarizes all the other slides, right? So first step is it systolic or diastolic? I think that's what the first step I gave you, right? Is it systolic or diastolic? That's going to separate it out whether it is a regurg or a stenosis and which valve it is, right? So you can think of the cardiac cycle, you can think it through. There's also the mnemonic called ARMS parts. Any aortic regurg or mitral stenosis that's ARMS, right? ARMS, or parts, pulmonic regurg or tricuspid stenosis. Those are always diastolic. So you don't have to think about it at that point, right? So if it's ARMS parts, we know it's a diastolic murmur. If it's not ARMS parts, then it's a systolic murmur. But you can just think it through. Aortic stenosis, oh yeah, difficulty squeezing my left ventricle out. That's a systolic situation, right? And then the second step is, where do I hear it best, right? Do I hear it best over the mitral area or the aortic area? If I hear it best over the pulmonic area, I might be in like right valve territory. But it's rare to have right valve problems. That's why we're only kind of go over the left valve stuff. All right, and you can grade that. Can you hear it with a stethoscope? Can you barely hear with a stethoscope? Or can you not hear it at all? You only can see it on echo. Or versus you don't even need a stethoscope. You just hover it over the chest, you can hear it. Or you can hear it from the door, right? So there are different gradings of valves. Usually in America, nobody gets beyond level 3 because they, it usually gets treated early in childhood. And if you really want to improve, you say, I really can't hear what's going on, you can have the line on the left side so the heart's closer to the chest. You can hear it better. You can use the bell of the stethoscope, so not the what's the word? The diaphragm of the stethoscope. All right, mitral area. That's where if you're looking for this S1, do I hear an extra heart sound? S3, S4. The mitral area is going to be best for that. It's the apex of the heart, closest to the chest. And again, on the left side is going to be helpful. All right, and then of course we have maneuvers we can do. This is usually more an outpatient thing, but you can in the ICU lay them flat and raise the head. So look, the murmur's better. or sorry, murmur is more pronounced. That is usually more blood equals more murmur. The only exception is which one? Is prolapse, mitral valve prolapse, right? All right, so that's the idea behind murmurs, right? So this table summarizes all the other slides into one little table, okay?